রিভু তুমি বললে শুরু করবো আমরা।
স্যার আমি জানাবো, কামরুল ভাই বললে তখন আমরা স্টার্ট করবো, সমস্যা নেই।
শুরু করেন স্যার।
স্যার আমরা লাইভ হয়েছি স্যার, উই ক্যান স্টার্ট।
ওয়াদুদ ভাই
আপনি শুরু করে দিন। না আমি শুরু করি, এরকম করছি।
ঠিক আছে।
Assalamu alaikum and good evening to everybody, and to those in the USA it will be good morning, I think. Today again we are going to enjoy a case-based ECG discussion, and today we are going to have some ECGs and discussions from Professor Shishir. Professor Shishir Kumar Bashak is a very unique person in the sense that he has gone to medicine with a degree in cardiology and internal medicine, but by heart, at heart, he's still a cardiologist. And actually, he's from Sylhet, my hometown. I often refer my patients in there that you go to him. You'll find out both you have any internal medical problem, medicine problem, or a cardiological problem. He's the right person to go to solve the problems. Today, I do hope the wisdom he shows in caring for his patients will be seeing that in his ECG presentation. Athar Bhai, would you please say something about Shishida?
Thank you, Dr. Abdul Wadud Chaudhary, and good evening to everybody. Really, I am very much pleased to introduce Dr. Shishir Bashak. Really, as Dr. Abdul Wadud Chaudhary told, Dr. Shishir Bashak is a unique man. Unique in the sense, he is a unique teacher, very academic person, very popular teacher, and is a research-minded person. Really, we love him, and he is loved by all his students. Dr. Shishir Kumar Bashak is unique also in that sense that actually he services in the medicine, but by heart he is a cardiologist. He has got all kinds of the qualities. Really, he is a unique person to me. So, dear participants, we are just waiting to see how he presents his cases. Dr. Shishir Kumar Bashak, really we are waiting for you. Dr. Shishir Kumar Bashak is the right person. Thank you very much, Dr. Shishir Kumar Bashak.
Thank you, Athar Ali sir, and Professor Dr. Abdul Wadud Chaudhary for the kind words, for which actually I do not deserve at all. So I am very grateful that I'm invited to such an enlightened gathering, who are very enlightened panelists in this ECG case-based study group. So সবাইকে আমি আমার সশ্রদ্ধ সালাম জানিয়ে আমি শুরু করছি। I'm sharing my screen. So we are starting a case-based ECG. আমরা চারটা কেস দেখা মানে বলার ডিসকাশন করার চেষ্টা করব।
Shishida, there are students from Nepal as well. So,
yes. So, okay. So this is the first case. 50-year-old woman with history of diabetes mellitus and obesity presents with dizziness and back pain. She also reports myalgia and anorexia. She denies any associated chest pain and is mainly focused on her back pain. So 50-year-old woman has history of diabetes. She is obese, presented with back pain, dizziness, and also anorexia. Denies chest pain, focused on her back pain. This is the problem and is the case scenario. And I am actually showing the ECG in the next slide. And the question is, let us see the ECG first. This is the ECG. Let us have a look on the ECG. And these are the questions to be asked, to be answered, actually. What is segment abnormality do you notice? What are the differentials, likely differentials? Would you activate cath lab or consider thrombolysis? How do you plan on treating this patient? Let us study this ECG. We have waiting rhythm.
I do think if the students can want to engage, they can raise
Yes.
their hand and answer it.
Yes, please raise anybody and answer. Try to answer those who are interested. We have an approach to actually read an ECG. We know there are different approaches followed by different ECG readers: rate, rhythm, axis, intervals, enlargements, and ischemia or infarction, or any other algorithm, any other sequence we can see. Any participants actually raise their hands or is like to comment on this ECG? Here we see the rate is actually regular. Rhythm is regular. Rate is actually not bradycardia, not tachycardia. Almost 90 per minute. Rhythm is regular. There is ST segment elevation seen in V1, V3, and V4 moving upwards. This is seen. So the question is, will you activate the cath lab where it is available, or we should plan for thrombolysis in this particular patient?
Can you go back to the presentation again?
Yes.
Whenever we see the ECG changes, that the ST segment change they were showing, will you be concerned if the patient do not have ischemic chest pain? For SS diagnosis, we need to have a clinical presentation as well as
Yes.
investigational findings.
That's
So
very
high or
important.
ECG change.
Yes, that is very important. That is very important. So chest pain is not there. Mainly patient is concentrating on the back pain, but patient has got risk factor for ischemic heart disease, diabetes, and obese, 50-year-old lady, probably postmenopausal. So in diabetes mellitus, patient may not complain chest pain, maybe engine equivalent or so. That is also I can argue also in this way. And the next step is we have done.
And that's the thing.
Did the patient have any previous ECG? Only this is the ECG? Or...
And this patient do not have any previous ECG.
That's one of the key findings. Whenever we have some difficulty with interpreting an ECG or having some difficulty in giving decision, we should look for previous ECG. That may help us tremendously.
Very good point. Very good point.
But
so we do not have any previous ECG. The patient has got risk factor for ischemic heart disease, but has not presented with chest pain. So we have done troponin I according to the protocol, and several readings are normal. What should do we next? And is there anything extra in this ECG? Should we look back again?
It's better to do an ECG again after half an hour.
Yes, that is an important point. But I stick to the ECG. Is there any thing we missed in this ECG?
What about the QT interval? Because
yes,
the QT interval they're saying, I don't think that's correct.
The QT interval we have to notice. So this is the QT interval for the participants from the beginning of the Q wave to the end of the Q wave. There are some intervals which are very important sometimes to measure in an ECG. So let us see the QT interval. Here we can see the QT interval here. Yes.
Yeah.
B2. QT interval is actually short. In this computer generated one, it is very short, 201. QT interval, corrected QT interval is 246 millisecond. Anyway, QT interval is short. So a short QT interval in this particular patient. So what are the differential diagnosis, short differential diagnosis to consider in this short QT interval? Hypercalcemia, digoxin toxicity, congenital short QT interval syndrome. So as this patient is actually 50-year-old, this is very unlikely. The patient is not getting digoxin. It is unlikely. The patient presented with back pain issue. We actually let us review the history again. 50-year-old diabetes, obese, back pain issue is there. But also there is dizziness, anorexia.
Anorexia. Yes,
So
yes.
we can actually go for hypercalcemia. We can suspect the serum calcium level was 14 milligrams per kg.
My.
So here is the important point. In hypercalcemia, the shortening of the QT interval is due to shortening of the ST segment. ST segment is shortened. There is no ST segment. Gradual shortening of the ST segment. With marked hypercalcemia, the wave appears to take off right from the end of the QRS complex. It appears to take off right from the QRS complex, giving it a pattern of ST segment elevation, so mimicking anteroseptal MI or MI. This is the point for which I have presented this ECG.
Beautiful.
Thank you. And here is some learning point for this ECG. ECG finding in hypercalcemia, ECG finding that may appear in hypercalcemia, prolonged PR interval, bradycardia, QRS interval widening, there may be bundle branch block, and ST segment changes that can mimic ACS. So, what is important that we should elicit a good history and look for short QT interval. ST segment elevation is not very uncommon finding in severe hypercalcemia. This is taken from literature. And next, so things are very easy. We need to consider the differential diagnosis of hypercalcemia. We know that here is some DD, hyperparathyroidism, primary or tertiary, not secondary, hypervitaminosis, Addison's disease, malignancy, skeletal mets, multiple myeloma, hazard diabetic. And you have to take the history in further details, and you will know the cause. And the actually hypercalcemia signs and symptoms typically manifest when this is between 12 to 14 milligram per dl. Watch for bradycardia and hypotension. So patient is feeling dizzy. Probably this is due to hypotension. So we need to give IV fluid resuscitation and other supportive care, consider bisphosphonate and all these things we know. So final take-home points from this particular case scenario with ECG is that differential diagnosis for short QT interval, there is no clear-cut mark below which we can call it short QT interval. Some literature says that it is below 400 millisecond. Our learned panelist will also comment on this issue. Hypercalcemia, decoxitoxicity, and congenital short QT interval syndrome, these three should be considered. There may be other causes as well. And in case of hypercalcemia, we should look for, while considering hypercalcemia, we should look for short QT interval. And ST segment elevation may be there that mimics ACS, which is not uncommon. And IV fluid hydration is the key treatment in the emergency department. Here I show a short video clip which depicts the changes in hypercalcemia. এখানে দেখাচ্ছে ST segment short. This ST segment will become shortened as calcium level increases. This take off from the end of the QRS complex. So QF changes may mimic ST segment elevation MI, and later on there are other changes as well. So thank you. I want to know comments from the panel of experts regarding this ECG that I have finished.
Dr. Shishir,
Yes, sir.
do you have the ECG after the correction of the calcium level? That is the
No, I haven't actually. I am not able to show the ECG.
Shishida,
Yeah.
what was the
Yeah.
final diagnosis? What was the reason for back pain? Was it some MET or some hyperparathyroidism?
It was actually shown, happened to be the skeletal metastasis. Back pain was due to skeletal mets. There was some malignancy detected, and it was the X-ray of the back pain showed the skeletal deposits.
It's very, very, very interesting case. Very interesting.
Very interesting. Yes.
So, Wadud,
Oh, Hafiz Bhai, welcome.
yeah, so now I just wanted to join
Please.
because I saw the speaker is Shishir, so it
Yeah,
is
thank you.
honor.
Thank you. Habib.
So
Thank you.
the
I'm so
one of
glad.
the pet question is in the board exam is this 59-year-old with confusion and the EKG.
Yes.
And what happens sometimes the fellows do not see the top line and they don't see the confusion part and they just try to read EKG. And I say that when there is a clue in the top, you need to look for, apparently normal looking, always look for intervals. 360 millisecond is the usual cutoff for the QT prolongation, if less than 360.
Okay.
But it needs to be very careful about this. This patient has very significantly reduced QT interval. So the confusion, back pain, we had one patient last week with hypervitamin D and presented with hypercalcemia and short QT. So these are the important things to pay attention to. About the ST elevation, my comment is that we have not seen much of an issue with the ST elevation and hypercalcemia, although in the literature, but my hunch will be that it is usually more pronounced in the presence of pre-existing LVH with
Yes.
hypercalcemia, that
Yes.
it makes it like worse. But there are some tricks for that, to how to figure that out.
Thank you.
Shishir,
Yes.
can I make a comment?
Yes, sir. Sir.
Yes, sir. Yes, sir.
Two things. First of all, I mean, we have been talking about clinical medicine for last few sessions. And the question is, in what context the patient presented and what is the EKG? So, I mean, the question choices are very, very good because shall I take the patient to the cath lab? But the point is the patient didn't have symptom at all. The one just thing about the EKG, if you look at the machine-read QT interval, is actually inaccurate. Please pay attention to that. If you look at lead V2,
Yes.
the QT interval is actually 300, at least 320 milliseconds.
Yes.
It's longer than what it has been measured by the machine. So that's wrong. But even
Yes.
then, it is short.
It's short.
Yes. So and beautiful, because many years ago I actually published some paper that once serum calcium goes over 40, you can see all kind of changes, including T-wave inversion, and that's a good thing to remember. But I think it's a good ECG. It opens our eyes that look, things are not always acute MIs. Things are not always intervention. There may be other thing to look for, because one of the things that if I paid attention to this ECG, otherwise I may not do a calcium level and I will miss a diagnosis. So likewise, other electrolyte abnormalities, sometimes the ECG may prompt us to do an EKG, electrolyte level on that particular electrolyte. Thank you.
Thank you, sir.
Sir, what will be the terminal event in a case of severe hypercalcemia? What will be the ECG changes?
The ECG change, Shishir actually showed everything. The ST segment part is actually, it is not ST elevation because the T wave comes so close, it looks like ST elevation. But there is Shishir also showed T inversion. That can happen. And we had cases like over 14, it starts happening. And by the time it reaches 18, it basically, you can see all the T wave changes, almost looks like ischemic changes.
Rafiq Bhai, good to hear. I'm driving to the hospital. Rafiq Bhai is in Las Vegas, actually. We had a good time yesterday with Rafiq Bhai, now in Vegas. And I'm driving because I have a patient, close friend of ours, mother is sick. And I did not, I asked Rafiq, are you going to join? And Rafiq said, I don't know. And I also did not know. And both of us are attending this session, and it's because that shows that we love this session, and the relationship of EKG session and is beyond EKG.
Yes.
So
Yes.
one thing is hypercalcemia, Rafiq bhai. There was a beautiful paper on in NEJM about the terminal consequences. I don't know whether this is proven or not, but the electrophysiologically, it can give this scenario like delayed after depolarization, and it can trigger the biventricular VT and then degenerate into VF. So
Yes.
any comment on that, Rafiq bhai?
Yes, I mean, the calcium current, but it's interesting that hypercalcemia will be serum, but when you have overloading in the cellular level, and if you look at catecholinergic polymorphic VT, the mechanism actually the calcium overload inside, so absolutely. But we haven't seen, actually, I used to looked at a lot of cases with hypercalcemia in heart failure. They don't develop that much arrhythmia as with other electrolytes.
Yes.
It's the intracellular load that can trigger the arrhythmia event. Thank you.
Beautiful session. The next case.
Yes, I'm proceeding to the next case. This is the second case I have actually telling it 2A, and so similar case I will label it as 2B. A 68-year-old man with end-stage renal disease is seen at his hemodialysis center. He missed his last scheduled hemodialysis session. What does this ECG show? This patient has got also other risk factors. He is also hypertensive. He is getting antihypertensive drug as well. And what we see in this ECG. Dear participants, you can participate. Anybody can raise hand and express your comment regarding this ECG.
Review, is anybody raising their hand for chat?
Why didn't you ask someone to come and talk?
Yes, there is actually
Mahfuzur Rahman.
let me start. There is a P wave before every QRS complex. PR interval is normal in rhythm. There is actually bradycardia.
What Rafiq sir has told us,
Yes.
to always look at the ECG as a whole, and আমি
Yes.
যেটা বলি যে খটকা লাগা, is there something wrong? And whenever I look at the ECG, the first thing that comes into my vision
But
is the very
fault.
prominent peaked T waves.
Yes, that's right. That's the thing. That's the thing is sometimes we diagnose things in two ways. We collect the signs, symptoms, and everything like in patients here, all the features, then we compile, then reach a diagnosis. And another is pattern recognition. By seeing a cat, we see cat. So Professor Vadhu Choudhury is telling a very nice one. So pattern recognition sometimes helps us. Just in one gaze, we can sometimes see the abnormality, and that is the key abnormality. So here is the tall peak wave. We call it sometimes hyperacute. We actually interpret here. So here is peak T, symmetrical, peak T, narrow based. And there is also, this is RWAVE in lead V3 is 33 millimeter, is one of the criteria for LVH. Patient is also hypertensive, as I have mentioned, though it's not full criteria for LVH. Here is QWAVE. So what could it be? We know that in acute coronary syndrome, as patient is hypertensive, and we know that CKD patients are also risk factors for coronary disease, and they die of coronary disease mostly, we know. So could it be acute coronary syndrome, the very hyperacute phase? And we know in hyperacute phase, there may be ST elevation is the first earliest sign, is electrocardiographic sign, or the hyperacute T may be the earliest electrocardiographic sign, or what else?
Can I interject?
Yes.
But in case of SCS, it's a regional phenomena. It's not a global phenomena.
Right.
But here we are seeing this is as a global phenomena.
Fine. That's a very interesting observation. Yes. Any difference between acute coronary syndrome patients and other differentials?
And another thing is the T wave, tall T wave that we see in hyperacute, they are rather broad-based. In case of hyperkalemia, that's narrow-based.
No, fine. Very good.
And also look at the P waves, because if you have very smallish P waves, that also support hyperkalemia.
Fine.
So let me tell you about the my experience is that often hyperkalemia can be associated with acidosis. And if that is the case, then this narrow base, broad base might not work. So you need to be very careful about this. And with the profound acidosis and hyperkalemia, then ST segment can mimic also STEMI. So too much broad base or narrow base, we'll keep that in mind, but that may not be the differentiating point. So I would rather say that if there is hyperacute T and the clinical context, then think about the differential. And you can, in a dialysis patient with this hyperkalemia until proven otherwise, that's your working diagnosis. Keep in mind the differential diagnosis. Also in this case, this is interesting because usually hyperkalemia with the acidosis and often with the hypocalcemia, QT is kind of normal, a little longer sometimes. But in this case, QT looks like, I don't have the measurement, in the lower side. Sometimes in the renal dialysis patient, they have what they call the secondary hyperparathyroidism. So be careful about those findings also.
Yes.
That's
So,
very useful observation.
Yes.
I'd like to make a clinical comment on that. As for example, when the clinical history comes, patient has renal failure, any fellow, any doctor goes to the room, always start thinking about whether there's any electrolyte issue on this patient. You start thinking about even before going to the room. So always look for any hyperkalemic symptoms in our EKG finding. And another thing I like to point out that our fellows needs to know what's the evolution of EKG changes with hyperkalemia. Because this is the hyperacute phase, peak T waves, then slowly widening, and then wide QRS complex, and then may go to cardiac arrest. So they need to be able to quickly diagnose those patients not having VT or something when they see wide complex. And in fact, the patient has severe hyperkalemia went so far. So the treatment should be initiated very quickly. And, and they need to know, initial phase of treatment of that. And particularly in patient with renal failure, normally they tolerate elevated potassium level at significant amount, because normally you don't see these changes in chronic dialysis patient. They have some tolerance of hyperkalemia. But if you see those evidence right now, as we see on the ECG, you have to take quick action on that.
Yes. Thank you so much. So as we proceed, I actually want to make some comments on this ECG. So here we find the waves are tall, peak, and symmetric, especially prominent on V3 to V5. Wave morphology is called, this wave morphology is called hyperacute and is seen with systemic hyperkalemia or localized hyperkalemia seen in early stage of an acute MI. I have gone through some publications where there is said this hyperacute in acute ST elevation MI setting is due to extracellular, localized extracellular increase in the calcium, in the potassium level, they are actually saying. So that could be the cause of hyperacute in the setting of acute ST elevation MI, but that will be regional. Professor Wadud Choudhury has told very rightly that they may be regional. These in the site of the MI STEMI where it is happening. In contrast, normal wave is asymmetric. We should mention in this regard. This is symmetric. This is asymmetric. So regardless of the amplitude, whatever may the amplitude is asymmetric. The upstroke of T wave is slower, while the downstroke of the T wave is faster. The T wave that are all peaked and symmetric, that is upstroke and downstroke are equal, are seen with hyperkalemia, which may be systemic or localized as in acute MI. So this is the different causes of tall T. Here we see hyperkalemia. For just theoretical purposes, this is symmetric, narrow-based, pointed, and tenting. Narrow-based, this is pointed, tenting is there. And what Professor Wadud Choudhury mentioned, this is broad-based, symmetric, but broad-based, not tented like this one. In hyperacute ischemia. In comparison to the normal variant, this is asymmetric. This limb is slow to rise to a peak and sharp fall. Asymmetric, not narrow. So in comparison, there is comparison between three distinct variety of waves is there. This is all, and can I move to the second one, next one, related next one?
But before that, Dr. Shishir Bosak, can you go to the your hyperkalemic ECG again, please?
Yes.
Dr. Shishir, although it is actually Professor Abdullah Wadud Choudhury nicely mentioned that the hyperkalemia is a global problem and ischemia is a regional problem, but still the tall peaked T wave is usually evident in the precordial leads, not in the limb leads. Is it true?
Yeah. Yes. They have also, relatively, they are more taller in precordial leads. Yes, you are right, sir. It is also mentioned here that it is especially prominent in lead V3 to V5 in this particular ECG, and it is actually more prominent in the precordial leads. You are right, sir.
Shishida, can I interject?
Yes.
For the young audience, for the very young, not for the specialists, when we call a tall T, if the T wave high is more than 5 millimeter in the limb leads or more than 10 millimeter in the chest leads, we should consider that it's a taller T. That's one thing we should remember. The second is, that's what I was saying, it's a global phenomenon because we are seeing tall T in lead 3 and FEF and also lead 2, 3 FEF, as well as in the anterior leaves. And ST elevated MI should be limited to a one arterial territory, not like this usually. So that's another thing we should consider. But we should remember that in a CKD patient, on dialysis patient, both SES can occur in presence of hyperkalemia as well. So always the clinical context and the patient's presentation, chest pain present or not, all these things are very important.
Thank you, Choudhury.
Very good comments. Thank you. I'm proceeding to the next related case, case 2B. 8-year-old women with end-stage renal disease, with diabetes mellitus, hypertension, develops an infection as a result of cellulitis at a nearly newly placed arteriovenous fistula. She developed cellulitis. Her blood culture are positive for staphylococcal bacteremia, and intravenous antibiotics are prescribed. 2 days later, her blood urea nitrogen and creatine level increase, and she develops anorexia and nausea, and ECG is obtained, which follows. So here is a patient, women, 68-year-old, end-stage renal disease, 2 risk factors, diabetic and hypertensive, septicemia picture, renal function deteriorates, nausea, anorexia, and ECG. This is the ECG. Any comment from the participants?
Yes, let us discuss what is the rhythm actually. Shishir Bosak.
Yes, sir. What is the rhythm? We see no P waves. We see broad QRS complexes, regularly placed broad QRS complexes. There is bradycardia. There is still all T waves.
So what are the differential we can place for this ECG, Shishir Bosak?
Sir, would you kindly make some differentials for this ECG, sir?
Professor Abdul Wadud Chaudhary, actually, he loves this ECG. That is, he has got a very popular Bangla term.
Elano Melano TV.
Elano Melano ECG. That is a very. So this is a classic ECG finding for the severe hyperkalemia. But before that, for the ECG practice, for concerning the ECG, what are the differential? Can it be tell it that the idioventricular rhythm?
Can I comment, sir?
Jamil, yes, please.
Since that the rhythm is coming from intranodal area without any P wave, and there is also bradycardia. Initial part of the QRS complex is narrow, and later part is widened. A kind of bundle branch type of feature. And this usually happens in severe hyperkalemia, and in the bottom strip it looks like sine wave, near about but not fully sine wave.
Yes.
So your diagnosis is hyperkalemia.
Most likely.
So let us see some findings on this ECG. So here we find regular white QRS, very wide, 0.28, complex rhythm at a rate of 48 per minute, 48 beats per minute. So there is bradycardia, white QRS complex, no evidence of atrial activity, and wave are symmetric. These are the summary findings here. QRS complex is actually very broad. So this is hyperkalemia, more marked than the previous one, previous case scenario, what I actually mentioned in the previous case scenario. In this one, the calcium level is probably is very high. So let us mention some learning points here. So hyperkalemia can cause suppression of impulse generation and conduction, resulting in bradycardia and conduction blocks, and ultimately resulting in cardiac arrest in diastole. And we actually review some ECG findings in the setting of hyperkalemia. Serum potassium level may not correlate closely with ECG changes. Not always. And all peak wave, which I mentioned in the first case scenario, that is on the hyperkalemia, repolarization abnormality is the earliest changes in the ECG, peak wave. So hyperkalemia is an emergency sometimes, and this should alarm the ECG reader or physicians to detect and to take the advantage of correcting it. ECG changes with potassium level more than 6 is P wave widens, reduction in amplitude. Professor Badr Choudhury said the reduction in P wave amplitude is also a point to be marked along with the tall peak T wave, and P wave later disappears. PR segment lengthens. When potassium level is raised further, more than 7 millimole or so, QRS complex further widens. Bizarre morphology, what Professor Badr Choudhury said, melanoma morphology is good. Bizarre morphology, sinus bradycardia, bundle branch block, high-grade AV block, and later sine wave appearance. And ECG more than 9, cardiac arrest occurs due to asystole, VF, pulseless electrical activity. So although this actually changes do not correspond to the level of potassium level always, but this is a guide how we can interpret ECG with increasing levels of potassium. And what is very important that this is the earliest change in ECG, and we should recognize it and we should correct it at this phase. And here is a short video clip to show the ECG changes. ECG may be thought of as a string, and this changes with increasing potassium level. And we see here normal ECG, tall peak T wave, broad QRS complex and P wave flattens, and QRS complex widens, progressing to the sinus wave, and then cardiac arrest. So, any comments regarding this?
Can you back to the ECG, please, again, Dr. Shishir? Dr. Abdul Wahab Choudhury.
Yes.
During the management of this patient in the ICU or CCU setting in this patient, it takes time to correct the potassium level. Does this patient need the TPM support, temporary pacemaker?
No, mostly no, because just nebulize the patient, give calcium gluconate and glucose infusion, insulin glucose infusion. You will find out the very rapid changes in the ECG because the rate is quite stable. So you can wait.
Yes, very good comment.
Rafiq sir, are you here? Or
Hafiz bhai? Aziz bhai?
Aziz bhai, are you here? I think network is very problematic today.
Oh.
Professor Tawfiq is here, I see.
Yes.
But it's a very good example of what potassium can do initial stage and in later stage.
Yeah, nice demonstration from the 2A and 2B ECG. Thank you, Dr. Shishir Prasad, for your excellent demonstration. 2A and 2B ECG.
Can we go to the last case?
Yes, yeah, please.
Okay. I'm going to the last one. This is case 3. Let us observe this ECG first. I'm giving the history just within few seconds. Here we see sinus tachycardia, P wave before every QRS complex. There is T wave inversion in V1, V2, V3, V4. Flattened is here, and also T wave in inferior leads, especially in C and AVF. History is 37-year-old obese woman presented with recent onset of shortness of breath. She denies chest pain, cough, fever, is normotensive, non-diabetic. Her previous ECG done just 1 week back was normal. Absolutely normal, meaning there was no T wave inversion in these leads. This is the history. Now, what is the interpretation of this ECG? Is there any differentials, or we could guess any diagnosis from this ECG?
Acute inferior MI, Shishir Prasad.
Acute inferior MI, sir, here the this QF, what is mentioned is this Q was persistent before, only this is new. And here is very narrow, no pathological QF.
But the ST segment in lead 3 and AVF, do you think normal ST segment in lead 3 and AVF?
Actually, ST segment is not elevated. It's isoelectric. There is
Yes, I see.
inversion and there is QAB. Yes, here is in AVF. We know that the isolated, if there is QAB inversion in lead C, maybe normal lead V1, AVR, but constellation of all this finding. What about this V1, V2, V3, and V4?
Yes.
And patient's history is obese 37-year-old lady with shortness of breath, no chest pain, cough or fever, non-diabetic, non-hypertensive, previous ECG normal.
How much obese? Morbid obese?
No, just not just crossed the level of overweight.
Has she any long journey or anything like that?
It is not revealed. There is further history. Patient is afebrile, respiratory rate is 24, blood pressure is 120/75, saturation is 92, breathing on the room air, and chest examination or other examination is unremarkable. So patient is tachypneic and hypoxic.
Pulmonary embolism ভাব একটা লাগতেছে তো সেই জন্য।
S1.
We
খালি
really,
S1 টা নাই আর কি, আর দুইটা আছে।
that's important.
Q3,
So
Q3 is there, but no S1.
that is very important key point. I am discussing in this following slides that what are the ECG findings in acute pulmonary embolism. This is one study by this author. His result was inversion is the commonest abnormality. Flattening is present in 30% patients. Sinus tachycardia is also common. So these three are common findings: QA inversions, QA flattening, sinus tachycardia. Rightward axis 11% is found in 11% patients. Is segment changes, either elevation or depression in 9% patients. The classic pattern which is described in the setting of acute pulmonary embolism, S1Q3T3 pattern, is only 4% found in this study. And in other study, this is less than 10% in patients. This is not common. What is important to mention here, this is uncommon. And sinus tachycardia, QF inversions are the common finding. Acute. And this ECG, another ECG, here we see this S1Q3 pattern. This is also called McGinn-White sign, relatively specific but insensitive. S1Q3 pattern. Here we see that there is no inversion in anterior septal leads. This is another ECG. Here is sinus tachycardia plus QF inversion in anterior inferior leads, inferior leads T inversion, and also S1Q3T3 pattern. So more the findings of acute P is present in a particular ECG, more the likelihood. I'm mentioning it here that we do not perform ECG for the diagnosis of acute pulmonary embolism, but it is said that pulmonary embolism is a great masquerader. It is very difficult to diagnose pulmonary embolism if it is not suspected properly. So in a breathless patient or chest pain patients, we do ECG, and we should not miss any points which is in favor of acute pulmonary embolism, and we should also exclude other differentials from this ECG. That's why I'm actually mentioning it here, because acute MI, pericarditis also comes in the differential diagnosis. So further, I'm discussing some points which are learning points. ECG finding in acute pulmonary embolism is generally non-specific and are likely to be caused by RV strain or dilatation. There may be no ECG changes in small, depending upon the amount of acute pulmonary embolism. Actually, we study from the books that pulmonary embolism may be small, that is low risk pulmonary embolism, or there may be submassive pulmonary embolism, as in this case, or there may be massive pulmonary embolism, which presents with severe hemodynamic collapse or syncope. This case could probably be submassive pulmonary embolism. The ECG finding in acute pulmonary embolism, let us actually review. Sinus tachycardia, S1Q3T3 pattern, rightward axis, new RBB or incomplete RBB, ventricular dysrhythmias, ST elevation or depressions. New tape inversion in anteroseptal and or inferior leads, that is the evidence of RV strain and ischemia. It suggests acute pulmonary hypertension and is equal to PE until proven otherwise. We should do other investigations and prove whether it is pulmonary embolism or not. So here are another few points. There are some ECG findings in pulmonary embolism that are associated with hemodynamic instability. We can forecast that this patient's BP is 120/70. But there are some ECG features which forecast that this patient may become hemodynamically unstable in following days and increasing the morbidity and mortality. These are Q-wave inversions in right precordial leads, as in this case, ST elevation or depression, especially ST elevation in AVR. Global ischemia is reflected by ST elevation in AVR, also in V1 and V2, tachycardia, in the form of sinus tachycardia or AFib or flutter, or signs of right heart strain, as evidenced by right axis deviation or tall R in V1. If we find this, any of the features or combination of the features in a patient with submassive PE, we should think that this patient may become hemodynamically unstable and may be a candidate of thrombolytic therapy. So the final take-home points from this case scenario is PE may mimic ACS. Make sure to consider PE in case of acute onset chest pain, although this patient has not got chest pain, and pay close attention to the new wave infarctions, ST segment changes, or ventricular arrhythmias. PE can also cause low-grade fever. Fever was not present in this one, but don't be fooled by just calling it as pneumonia. In case of tachypnea or low oxygen saturation, low-grade fever, we may think of pneumonia, but this could be a PE. PE findings are associated with some predictive features of hemodynamic instability that I have just mentioned. There may be tachycardia or sinus tachycardia or AFib, and there could be some right heart strains. The features of right heart strain, as evidenced by right axis deviation, tall R in V1, etc. Thank you. So, any comments regarding this scenario, last scenario from the expert panel?
Dr. Shishir, did you
Yes,
do
sir.
any other test to confirm the diagnosis in this case, this particular case, that is the like the X-ray or other test, that is a
Yes,
troponin like this?
we should do chest X-ray PA view. In this particular chest X-ray PA view was normal. We should do also troponin I. The patient was breathless. We should perform NT-proBNP. And finally, if there is D-dimer, and we should clinical susceptibility
CTPA.
score is there. And finally, we should do CT pulmonary embolism, CT pulmonary angiography, CTPA will confirm the diagnosis.
So other than the obesity, was there any point that you at least to the diagnosis that this patient may have the pulmonary embolism other than the obesity? Was there any predisposing factor in this case?
Yes, sir. Professor Wadud Chaudhary actually mentioned, was there any history of immobilization or long journey? This is not actually present in this particular scenario, and this is missing from the history, and we should ask the patient further. We have mentioned very short history that lacks this information.
I'm interested to know whether long-term use of OCP in such a patient has anything to do with pulmonary embolism. Because OCP use in certain patients can lead to DVT.
Yes.
And that can lead to pulmonary embolism.
Good
Recently,
point.
actually, in Bangladesh Specialist Hospital, a surgeon has done a perianal abscess drainage. The next day, that night, around 11 p.m., I was called in. The patient was very restless. Saturation, he requires oxygen, around 6 liter oxygen. They did the ECG, and that ECG shows S1Q3T3. They did have an X-ray that was quite normal. The patient's previous ECG I asked for, and it was not there. That was one rare case of S1Q3T3 that I got. Well, I start the heparin immediately, sent the D-dimer, and the next day they did have a CTPA, CT pulmonary angiogram. But the patient improved tremendously within 24 hours, within 12 hours actually. The next morning, patient is already feeling better. And the most interesting thing is, I just have a look at the patient's lower limb. Her left calf muscle was a little bit swollen compared to the right one. The left thigh was also similarly. There was a difference of around 1.5 centimeter in the calf muscle, around 3 centimeter in the thigh muscles. Actually, we did have the measurement done. I asked the junior doctor, please do it and notify me in the next day. The CT pulmonary angiogram showed there was evidence of pulmonary embolus that has been scattered and distributed peripherally. Actually, starting the heparin very early on has resulted in that the thrombus did not progress and it becomes dissolved and scattered, and patient improved. I see the patient only 2 days ago. He has just followed up. He's completely normal now, no problem. Echo and everything was normal. And another thing is that in pulmonary embolism, unless it is massive, you do not actually find anything abnormal in the echo. If you get RV-RA dilatation, that's a very helpful thing, but you may not get it. You may see the thrombus in the pulmonary artery or in the RV tract or in the branches if there is massive thrombus. But in smaller cases, smaller pulmonary embolism that is scattered in the distal vessels, only the CTPA can actually show it. Otherwise, you cannot expect that to see in an echo or anything.
Yes. Very good case. And actually here, what is important is the high degree of suspicion to diagnose acute pulmonary embolism, and early intervention is the key. Very good case you have described.
And observation actually.
Yes.
I just went in, only one of his leg was showing, and I see that it's like a little bit swollen. I just exposed the other leg, compared the two, and I become convinced that it's the case of pulmonary embolism. The most important thing is the patient did not have any risk factor whatsoever. He's not he was not hypertensive or diabetic or obese or did not have any other problem, any other health issue. The perineal abscess was the acute case, and it was dead only 1 day ago, and he had that fever and everything, only 4 days history total. But even then, he developed pulmonary embolism and DVT. That's very surprising.
Thank you, Dr. Shishir Borsha, for excellent demonstration of different kinds of ECG in pulmonary embolism. Dr. Shishir.
Yes, sir. Yes, sir.
Dr. Shaila Nasrin has suggested that she should undergo protein C and protein S analysis.
Yes, yes.
So anticoagulant deficiencies like antithrombin, protein C, protein S should be done also. Yes, right.
But remember that if you do not send in early on, then if you start anticoagulation, then you have to stop the anticoagulation later. And after an interval of at least 2 to 4 weeks, then you should send this test. Otherwise, it will be false negative.
Yes.
Thank you, Shishida. These are good cases.
Thank you. So I have actually presented 3 cases, one on hypercalcemia, 2 cases on hyperkalemia and pulmonary embolism. Both may mimic acute coronary syndrome patients or acute ischemia patients, ST elevation, STT changes. So what is the message is that actually we should interpret the ECG in the light of the history and we must keep our thinking perspective or differential diagnosis wide open so that we can catch all the possibilities and we can intervene the deadly things very soon and start start treating the emergency patients and save lives. In
Dr.
some cases.
Shishir, sometimes the marginal changes of troponin level again confuse us. Did you do that troponin in this case? What is the troponin level? Do you know?
Actually, troponin level may be increased because of the right ventricular stress here. Troponin level may be increased and may confuse this picture. But as this is strain pattern, not an acute MI, the troponin level will serial troponin level will not be just rise and fall that follows in acute MI. This will be minimal elevation and will actually be horizontal curve, plane curve. Probably that will differentiate between an acute MI and the troponin level that is raised in the setting of acute PE.
Thank you very much. So any comments from other participants, that is panelists? Jamil, Shafiq. Dr. Shishir,
Yes, sir.
you can stop your screen sharing, then you can.
Okay. Okay.
I was telling before that Shishida will bring the internist perspective into ECG interpretation. I was very right. Particularly the first case was a very, very important case, first one. And I always tell that you should always have a wider horizon, a wider thinking process. And as Rafiq sir always says, look for the differentials. What other things can happen? What other things can be responsible for these changes? We should look for that.
Dr. Abu Naim, can you hear us, Dr. Abu Naim? Can you unmute?
Yes, sir.
I said, did you follow the cases presented by Dr. Shishir Bosak today? You are the young participants. Dr. Abu Naim.
Yes, sir. জি স্যার সবগুলা কেস স্যার শুনেছি স্যার
Now, can you correlate whether you have experience of similar cases, as I was saying? If you have any experience of similar cases, that just go back in your mind and think whether you have missed something, similar cases.
স্যার ইমার্জেন্সি ভাবে স্যার এরকম কেস স্যার দেখিনি স্যার তবে এরপর থেকে স্যার দেখলে স্যার সাসপিশন আসবে স্যার
Suspicion aspect. It important. That's the most important thing we are trying to install in you. Thank you. Atar Bhai?
Dr. Jillur Rahman. Jillur, can you hear us? Dr. Jillur Rahman, can you unmute yourself? Dr. Jillur? So, Dr. Abdul Wahid
Sir, thank you, sir.
Yes, Jillur
Thank you,
Rahman.
sir. Thank you, sir. Sir, I always follow your group, but I never talk in this group. So, sir, before today's presentation comments, I like to thank sir you and my other teacher Abdullah Chaudhary sir to create this group and teach us. I am learning, sir. I am always learning, sir. You know about Shishir Bosak. When I was the student of Sylhet Medical College, you know, sir. We know that Shishir Bosak is internist, but very popular physician in the Sylhet town. When I was in the maybe first time in Eastern Professor, sorry sir, Dada will come to NICVD for 15 days or 1 month to see the cath lab. But today I think what we see, it is excellent, sir. I to say it is excellent, as I do not know about him very well, but I know he is academic, he is good clinician, very popular physician in the Sylhet city. So today I could say maybe he is now very popular teacher, I think, in the Sylhet M.E. Josmani Medical College. Thank you, sir.
Yes.
Thank you once again, sir.
Yes.
Thank you very much for your comments. Nice comments. Thank you, Dr. Jilur Rahman.
So actually, Dr. Shishir Bosak has proved that he is a unique teacher. He knows how to present the cases, how to, no, really, Shishir Bosak, your collection, presentation, and the preparation of the cases serial by serial is unique, really, I think. I must congratulate you. And
Thank
I think our participant has learned a lot. Particularly me, myself, actually, I've learned a lot from your presentation. Beautiful presentation of the short QT interval, really. It was a nice case. And finally, the pericardial effusion. So, Professor Abdullah Choudhury, you can wrap up the session.
Actually, I always find something interesting in each and every day in my practice and also in my working place. You can see a lot of ECGs and they can tell you a story. If you have the mind to read it carefully, with respect, with affection, I would say, the ECG will embrace you like anything, will give you comfort, will puzzle you, will make you worried, and will make you happy. When you reach a conclusion and that comes out to be correct, it gives you the pleasure of doing something really great. A simple ECG, a bedside test, but immense in its capacity to ignite the thinking process. In a particular case, it may be very simple, but in a particular context, the same ECG may be very important. This perspective of looking at the ECG, enjoying it, analyzing it, that's what we are trying to do with this ECG study group. We want to ignite your, I should say, sense of enjoyment with ECG. Let us together play with ECG, learn with ECG, enjoy the ECG. Thank you, everybody. And review, you and your team, thank you again for being with us all this time. And the audience, as always, thank you.
Thank you, Dr. Shishir Bosak. Thank you again.
Thank you, sir. Thank you, Professor Badut Choudhury.
শিশিরটা খুব চমৎকার হয়েছে কেসগুলা। আপনার ওই যে পরে যে এগুলা দিচ্ছেন, এগুলো হলো যে লার্নিং পয়েন্ট গুলা, টপিক গুলা, এটাও আমাদের ছাত্রদের জন্য খুব ভালো, কারণ এটা তো রেকর্ড থাকে, ওরা পরে দেখেও এটা কিন্তু অনেক কিছুই করতে পারবে।
সেটাই।
ভালো থাকেন।
Thank you.
Good night.
Good night.
Next Sunday, good night.
Good night.
Assalamualaikum, sir.
Walaikum salam.